All right, welcome everybody to the latest episode of the Interventional Endoscopist. I'm your host, Munkovo Suchdave. Today, we're going to be talking a little bit about a new device that's been on the market for a few months now. We're going to talk about the Dragonfly Cholangioscope. And with me today, I have two of the co-founders and inventors, co-founders of Dragonfly Endoscopy and the inventors of it as well. Both Mr. Jeremy Starkweather and Jason Ylizarde, guys I've known for a long time. I met Jason for the first time when he was with Beacon Endoscopy. He was he was selling the needle. He was his, director of sales, I think, for the country. And I reached out to them after I saw the Beacon needle on Med Gadget, and he came out to Phoenix and we got to use it. It was a great needle at the time. And then Jeremy, I've known for years because of his involvement with Boston Scientific. I think the first time I met him was about 2012 or 13 when he was the director or the global manager for wires. So welcome, gentlemen. Thank you guys for joining me. And it's great to have you guys on the podcast.
Thanks for the opportunity. Looking forward to the discussion.
All right. So before we get into Dragonfly and everything like that, let's talk to Jeremy first. Jeremy, tell me a little bit about your background and your childhood, where you grew up. Tell me a little bit about who you are and how you got to where you are today.
Yeah, so grew up in the Midwest. I'm originally from the deep southern part of Illinois, and then went to school in Oklahoma, got a business degree. And while I was there, actually, one of my friends' father was in the medical device world, and I quickly pegged that as a place I wanted to be, something just beyond selling a product or a good, something that actually could impact a patient's life. And that's what really directed me into that industry. My first opportunity was in the orthopedic space, trauma, hips, knees, but I believe my career really started when I at the age of 29 in 2003, got a job with Boston Scientific. So had a great career there. Was there for 11 years, gained a ton of experience in multiple different roles, but really started to gravitate towards new innovation, whether it be commercial, whether it be evaluating small startups in the GI space. And a really valuable experience that I had was as senior global product manager for pancreatic biliary, where we had the opportunity to meet, and really that position allowed me to meet a lot of leading key opinion leaders at academic medical centers or teaching institutions. During that time, I became exposed to Ex-Lumina. Joined them before FDA approval of the Axios stent. We built the team, we launched that product, and everybody that's probably watching this podcast knows the rest is history with Axios. And that's where I had the pleasure of working with Jason. After Ex-Lumina transitioned to Boston Scientific, Jason and our whole team went to Medigas, which was an luminal stapler for GERD. And that one wasn't as successful. Incredible innovation, just wasn't quite ready for prime time. So as that was shutting down, Jason and I got together and said, what else can we do that might be exciting and impactful in the field of interventional endoscopy? And that's what we're here to talk about today.
That's awesome. And so, Jason, how about you? What's your story?
Yeah, so I grew up in Baltimore, Maryland, mainly an East Coast guy. And then finally, I went to school at St. Bonaventure University, graduated in 1996. I was actually a tennis player there. And then I stayed on as an assistant coach for the tennis team. That was really my excuse of trying to figure out what I was going to do for the rest of my life. And I didn't really know what I was going to do out of college. So I stayed on there as a tennis coach, and then finally got my first entree into the med device world in the late 90s, was on a company, and we sold repairs to scopes, so endoscopes and rigid scopes in the OR. And then after that first year there, I actually landed a gig at Fujifilm at the time, Fuji Endoscopy. We were still trying to make inroads into the endoscopy market. Was a sales guy with them, and then I started climbing the ladder there, was a trainer. Then I went in for product management. I was actually there when double balloon was launched in America in 2004. So I led the double balloon launch in the US. And then I had a little stint at other different companies to get some marketing experience domestically and globally. And then I rejoined into the GI world in 2010. I joined the Cell Visio, the Mauna Kea market development team. I was there until Beacon. Beacon, I was the lead commercial guy with the Beacon needle. And then after that, exited with Covidian. I joined up with Jeremy at Lumina and Medigus. And from there on, we were on the same team.
So you guys have basically a parent company that you call Monarch Partners, and then you have Dragonfly as one of the companies underneath that. Tell me a little bit about Monarch Partners, what it is, and what the thought process behind that was.
Yeah. Let me provide a little clarity on that. Monarch Partners and Dragonfly are separate entities, and we do that on purpose. So Monarch Partners is a small group. Me and Jason, John and Lynn, and we've just added Tony Sullivan, who's got a tremendous amount of experience in the space. And you can think of Monarch as a company that develops innovations in the GI endoscopy space. And also there's some transition. There's also some pulmonary platforms that are in there also. Mm-hmm. So Monarch Partners is a collection of individuals that are going to execute from a leadership standpoint in the developments. Now, the folks at Monarch just happen to be the part of the leaders of Dragonfly. But as we develop Dragonfly, we also have another co-founder of Dragonfly, Tristan Springs, who has got a development experience in multiple spaces, but also in GI endoscopy. So he's one of our original co-founders. And that theme is good to, let's call it rinse and repeat, because we then pull together all of the prior external parties. So we model this a little bit different. We act as executive leadership. We get the right partners, expert engineers, contract manufacturing, clinical and regulatory team, put in a quality management system, and so on and so forth. So we kind of like to describe it as a med device in a box. Because what we don't do is we don't build out massive organizations that require a lot of burn. We try to do this in an ultra lean fashion as individual companies. So then we can meet our ultimate goal, which is to get our devices that have been developed into the hands of already existing commercial entities, which are your well-known names in the GI endoscopy space.
So then let's kind of shift gears to Dragonfly. So Jeremy, if I remember right, when you first told me about Dragonfly, you mentioned to me that Jeremy and you came up with the idea on the back of the cab. Talk about a little bit about how you guys came up with Dragonfly and the thought process behind it.
Yeah, you know what? I'm going to kick this to Jason because I think he tells the story better. But it did get invented in the back of a cab. That's one of our cool stories. So go ahead, Jason.
Yeah, so it really started with the why. You know, we're big on mindset when it comes to approaching device development, and you know, some of the first things we started wondering was like, why? You know, if I were to even step further back, you know, this wasn't just about, hey, let's just go build a better cholangioscope. This was about, from a broader perspective, taking a step back, using our, little, seeing to the future ultraviolet flashlight to see if there's any anomalies happening in the market. And what uncovered that was really identifying an area where we were starting to ask a lot of questions. Why in 15, 20 years has there been innovation, but very incremental innovation, yet clinical challenges still existed? And when you start asking a lot of questions of why this, why that, you get to a situation where there was an opportunity to develop something innovative. And so, if you approach this project with the question of how do I build a better cholangioscope, you actually already narrowed down your focus, because when someone hears cholangioscope or scope, you actually think of maneuvers that are very traditional and conventional in frame, such as an up, down, left, right dial of a scope. Well, when you start, again, asking tons of questions, you actually understand that those things take up space. So it just kind of starts evolving from that point. And we were like, the whole point is, how do we get to all the areas of the duct with as little internal guts as possible, to free up space to make bigger channels. And then, you start again asking these questions over many, many months and years. And you get to a point where you can actually start with a clean slate, develop something super novel, and at the same time, address all the clinical challenges that have been existing for a long time, such as smaller biopsies, distal duct stability. There's a whole host of things, ergonomics of a design. So there's things that you can actually just start addressing without any restrictions on how you approach the project.
Yeah. Let me add to that a little bit. It's interesting. I had the pleasure. I have a lot of respect for what Boston Scientific has done for the GI endoscopy space over the decades, and I had the opportunity to launch the original Spyglass, and then I was at a front row seat to all the development of DS, and then when you take a step back and you look at the history of cholangioscopy, you're like, there's been a lot of iteration, but not a whole lot of innovation.
Exactly.
And so why does there need to be a new innovation in this space? Well, number one, can you improve clinical outcomes? If you can't improve clinical outcomes, don't even do it. And when I say improve clinical outcomes, I'm talking about specifically in that first cholangioscopy or pancreatoscopy procedure. And so start to identify those, and then you say, okay, I think that there's some room for improvement here. There's room for innovation now. And then it's really an exercise of, as Jason kind of alluded to here, what have physicians told us over the decades that they want? Keep it single operator, give us great visualization. Don't make it bigger. That was one thing that we heard clearly. Because as you start to get deep into the pancreas or into the pancreatic biliary system, the ducts get smaller. So let's keep it the same size or smaller, I think is a reasonable thing to think about. But give us a better working channel, a bigger working channel, so we can do better accessories. And I know we might talk about this later, but what else do we think is in the future of cholangioscopy? Improved device passability. It's a very simple thing, but it's also a pain point. So when you start asking all those questions, you're like, okay, something has to be invented here that's new. And then Jason and I leaned on our experience of EUS and Axios stent. And we were like, what if we didn't make this loop to go down the scope? What if we just attached it directly to the working channel and brought in rotational capabilities? So that was the conversation that happened in the cab. I don't even know how long it was. It was probably a 30-minute ride. And then I hopped on my iPad, drew a couple pictures, sent it over to Jason. Then we started getting feedback. And then we're like, okay, conceptually, this might make sense. Neither one of us are engineers. So that's when you got to go find great engineers, right?
Yeah.
So that are super capable.
Well, yeah, and it's interesting because, like, from the clinician standpoint, right, a lot of times we'll have ideas and we'll say, well, why don't you just make it this way? And then we realize that the engineers are like, hold on a second, you can't just do that, so that's important. But was there, Jason, was there one specific pain point that you, like, Jerry mentioned a bunch, like, ergonomics, he talked about moving the scope around, how it attaches. Was there one specific pain point that both of you, but Jason, we'll start with you, that you guys were trying to solve, one that you heard over and over again that you thought was like, this is a pain and this is the one that we need to fix?
That's a really good question. I would say what we did not do was just focus on the feature and benefit specifically of a device. Again, when you kind of approach something very untethered, you actually come at a completely different angle. And what I mean by that is we don't just say, hey, let's build a rotating cholangioscope. There may be doctors that are so unfamiliar with this movement that have challenges and when they're initially trying it to really get a hold of why is it rotating and how to control the rotation. This wasn't about building a rotating cholangioscope, but what ends up happening is when you start asking the questions, like when you think about the designs of conventional devices out there, they're fixed catheters. So a fixed catheter, it's attached to a scope, they loop around, it goes down the channel. You actually lose all sense of endoscopic movement that physicians they've been trained on. That's all they know. Just imagine luminal endoscopy. You push an endoscope in, you don't just immediately fiddle with the dials and get your scope in a hook position and drive it. You actually use torque first, right? your body movements, you're using the torque of the scope, you're using up, down a little bit with your hand. And then when you go to do precise targeting, you actually hone in on the dials and use that for movement. So we knew by attaching to the biopsy channel, we were going to be able to unlock a maneuver that has been very familiar with endoscopists this whole time, but it's never been a part of cholangioscopy. Right. So it's really one of those things, again, when you approach something from a completely clean slate, you actually can go down the list of all the clinical challenges that have existed and knock them out one by one with this novel design.
And Jerry, one quick question. When you guys sat in the cabin and talked about this, was there, what brought this to both of your minds? Like, why did you guys start having a conversation about cholangioscopes? Because, you know, you left the company that made the Axios, you're in your, you know, you guys are doing this GI Shark Tank. What was it that kind of triggered the thought for you guys? Like, hey, we need to look at cholangioscopy. Oh, you're muted. Oh, sorry.
Sorry about that.
Yeah, no worries, no worries.
It's interesting. Our background were critically important here because we had this exposure to all the great things that you get in a large corporation. We then had exposure to this startup phase where you get even more closely intertwined with R&D and product development and so on and so forth. And I think what compelled me is I felt like we could do something that was more impactful to the GI market than if I would decide to go back to the corporate environment. So me is a lot of the reason I had the desire was I felt like I could just bring more to the space.
Yeah.
And yeah, go ahead, Jason.
I was just going to add one thing. I apologize there. You know, part of it when you're initially trying to innovate too, you know, you're trying to look at market trends, what's going on in the industry. You know, let's use cardiac as an example. They're innovating and evolving technologies every 12 to 18 months. Yeah. GI has not been that historically. But when you take a broader look at the market and you wonder why, say, one or two companies are dominating in a certain area, you could just hone in on and just like understand, okay, over a very large period of time, how much innovation has happened. And we just happen to find that we were satisfied with the level of innovation that was happening. And we felt we could just do better. You know, if you just kind of put it into a most simplistic terms, we believe there was a better way, right? And that's a lot of part of that speaks to the mindset of how we approach this.
And to you guys' point about, you know, iterations versus innovations. If I look back at kind of, you know, I started doing interventional endoscopy in 2010. And I think SPY was introduced in 2006 or 7. And the first time I got to use it was 2010. And I was looking around me and in the Valley in Phoenix, not a lot of people were doing it because, you know, that iteration required the fiberglass, it required the catheter, kind of long to set up. And you didn't see a lot of people adopting it. A few people did, but not a lot. And then when they went digital, that was not just an iteration, that was innovation, going from a fiberglass to a digital. And then you saw a lot more people. But then, I don't know, but you guys may have studied this number, but it seems to me that over these last 5 to 10 years, the number of people who have been doing cholangioscopy hasn't really logarithmically gone up. It's been more of a kind of, and not even a steep curve. It's just probably going up like this. But what did you guys see when you did some market research on that?
Yeah, I think one thing that became obvious was academic medical centers, tertiary referral centers, or physicians in the community that get referrals were really the market, right? Mm-hmm. And so, but there's still plenty of GIs that are doing cholangioscopy, or I'm sorry, doing ERCP, that don't do cholangioscopy.
Right.
So why is that? Well, they might not have an hour and a half, 2 hours to do an ERCP. They might have a challenge in that first procedure. You know, I don't call it failure. It's actually the goal of that first procedure in a stone case is to do the most effective lithotripsy that you can do. Mm-hmm. Even if you place a stent and have to bring back sweeps again, you hope to have a first procedure success. And so I think that we've kind of hit a plateau of like more broad adoption because still today, it can be a grueling procedure. It's buff. And so, when a clinician in the community does a cholangiogram and sees a 2 millimeter stone, do they even make the attempt? Do they have the right tools to make an attempt there? Or are they just going to throw a stent in and send the patient to a tertiary referral center that is willing to take more time to achieve the desired clinical outcome? So I think that we've had a little bit of stall in growth. I have to give Boston Scientific a ton of credit for what they've done related to physician training and education, and actually the growth of cholangioscopy. They're the ones that are the center of that. But I don't think we're done. I mean, cholangioscopy is not going anywhere. I think that there needs to be a requisite recognition in the market that we should still try to achieve more. And I think that that's the real goal.
Yeah.
So
I'm very bullish on it because I use this example when I'm talking to medical students or residents. And I said this in the last podcast where I talked about cholangioscopy is if you look back at the 70s and 60s, the way they found polyps was barium enema, right? Or colon cancer. Colonoscopy starts and now you rarely do a barium enema or anything like that. I mean, there's reasons to do it, but it's not something commonly done. But even to this day, we're still just doing a barium study of not barium, but a contrast study of the bile duct, where we really have a lot to learn on what the inside of the bile duct looks like and how to really tackle strictures and disease processes as well as stones. And so I just think cholangioscopy is going to grow because if you can see something, why wouldn't you versus looking at shadows and x-rays and things like that, So I think there's huge growth waiting to happen in that specific subset of interventional endoscopy.
Yeah. And you've got to think that in this space too, as more competition starts to happen in the space, everybody's going to get better. Mike and Tech will try to make improvements, and Boston will try to do improvements. Dragonfly will make some improvements. And the better these technologies get, the better the first procedural clinical success will be, which actually is the real important thing because that's the best thing for the patient. So let's just that should be the goal. And that's actually why Dragonfly exists.
Yeah, and then when you start adding, sorry, and Jason, but when you start adding that the IR guys are now doing a version of cholangioscopy, and the surgeons are now getting a version of SpyScope, and probably ultimately yours as well as Microtech's at some point. More people are going to be doing it, and there's going to be a higher standard of care and a higher level of bar to cross. Sorry, Jason, I didn't mean to cut you off. What were you going to say?
No, it's okay. I think this is an appropriate time to kind of talk about how we approach this type of space with innovation. You're going to hear me probably use the word mindset a lot. This has to do with more of an infinite mindset to the space. What I mean by that is we're already thinking of ways of how to make things better that we're even providing, right? So like there's different ways to approach biopsy. There's different ways to improve how lithotripsy is done. So we're already on to thinking about the advances of how do we leapfrog ourselves and keep pushing this space forward, because this is not about a finite endpoint of, okay, we developed this rotating, device that's novel, etc. We're already thinking about the next thing, and it's about perpetuating the innovation as opposed to being stagnant and satisfied.
Absolutely. So why don't you guys please share with the audience kind of, because a lot of people have heard of Dragonfly, a lot of people haven't had the advantage or opportunity to see it or touch it. So explain to me or explain to the audience the scope, what the form factor is like. We'll show some pictures as well during this discussion to kind of show the audience on the YouTube portion. But kind of just walk us through the design, the form factor, the ergonomics that we touched on, and the scope in general.
Yeah, I mean, the first thing that's obvious and noticeable is how it attaches to the scope. And it goes directly down the channel, and it's roughly the same length as if you would attach an Axio stent. Now it looks long, but once the clinician advances the scope into the duct, the hands become neutral. They're like together, which is a very natural and ergonomic position. And then you rotate the handle with the gray knob, and then you tip deflect with the blue knob, or turquoise knob. I'm sure exactly what color we have here.
Contract.
But the way we collaborate and work and train with clinicians is your first default is to go rotation, just like Jason said. You're torquing this thing away from the wall as you're moving it up, rather than tip deflecting and moving it up, and then you're into another wall, and then you tip deflect the other way and move it up, and you're into that wall. You're doing a rotation movement, and once that rotation movement with that lower knob is learned, it becomes very, very intuitive. And then when it comes to targeting, that's when you typically see people go to the tip deflection. So that's kind of the functionality, and you can actually basically slide the handle forward, which gives you 20 centimeters of travel up into the duct. We've yet to do a case where we needed more than 20, so we think that that's the right amount. But the catheter shaft is one of the keys to this. This is a braided hypotube that is designed to rotate. So it's not just a plastic extrusion. It actually has some torqueability by design. And that change in functionality actually allows us to not increase the scope size. It's still 10.5 French, but it gives us an accessory channel of 1.7 versus the 1.2. What that 1.7 allows us to do is to deliver a 1.5 millimeter biopsy forceps, which takes bigger bites. It's simply due to the internal size of the cup. We actually had that device manufactured for us. And then also a large EHL probe, going from like a 1.9 French up to a 4.5. You deliver more energy. You deliver that energy longer. I do want to take a moment to give a shout out to our engineering and contract manufacturer collaborators. The engineers that were brilliant behind this design were guys at Render, that's RNDR. The two primary guys that we worked with on this was Anthony Applin and Ben Morris, geniuses in the space. Because what is not seen is what's underneath that catheter, which is a series of gears. So you can imagine that this thing rotates 360 degrees or beyond in both directions. But you also have cabling, irrigation. You have all of this stuff on the inside. And if you don't have this engineered properly, you're going to twist it up in a pretzel. But that gearing system actually also provides like an auto locking type of mechanism. So you can move it in millimeters, take your hands off of it, and it holds stable, which is a big deal. Also, the design allows for better device passability. There's some secrets in that catheter that actually allow that device passability to be improved. Because the worst thing is getting to where you want to deliver your accessory and then having to move your scope and not getting it there. So that's a quick overview. Jason, did I miss anything? I'm sure I probably did.
No, actually, your description is perfect. Device passability, I think that it's a very underappreciated element that you don't really see, but people notice when they're using it.
Yeah.
When you any presentation that has been done on cholangioscopy in the however many years, there are some challenges that always pop up. Device passability is definitely one of them. It's because you get ovalization of the current channels. You won't get that with Dragonfly, and that's about as simplistic as I can put it.
Yeah, I do agree that the number one complaint I hear from my interventional colleagues is getting the biopsy forceps, and all these little tricks about, pre-grooving them, lubing them, walking the dog, and a lot of people are listening who do that will understand what I mean. Yes. But that part has been a challenge, and I didn't get to use a biopsy forceps on a Dragonfly, but I watched a friend of mine do that a few days ago, and he had no issues getting it up there. So let's talk a little bit about compatibility on the Dragonfly, just for the people who don't know. Is it compatible with the major scope manufacturers? What are the things that we need outside the scope to get this device working?
Yeah. Jason, do you want to take it?
Yeah, actually, that's obviously part of the approach is you got to make it work with everything. So there's only really two sizes to ERCP scopes out there. They're either going to be 124 centimeters or 125. And you got to make a a Dragonfly that actually works with all scopes, all sizes. So, yeah, in terms of compatibility, it's about as compatible as you can be in this space. We have a small video processing unit that we call the Dragonfly digital controller. It's basically a small little console. The funny thing is we could have made that the size of an Apple TV, which is very, very small, but we decided we needed it to be a little bit bigger because you actually don't want something so small that it's going to flop around on the cart. So what the funny thing that a lot of people don't know is that our initial vision of this was a Bluetooth wireless type of device that was just going to connect wirelessly through to a console. But that was a little far reaching. I think we landed on a good minimum viable product, which was just something with a smaller console. Some of the initial inspiration was how do we get a device like this that can have a global reach? And one of the thoughts that came to mind was, if you ever go to some of these third world countries where scooters are being used everywhere, could this be something that can be put on the back of a scooter, and rode up to some far outreach city, all in one compact backpack, right? So it was just kind of this vision that we had of how do we make the smallest footprint as possible with this design.
And that's important because one of the biggest things I've noticed over the last 10 to 15 years is every new device that comes out has its own generator, so it's almost like we're going to be the future of endoscopy. You're going to have a wall that has your lithotripsy, it has your scope processor, it has your cryo processor, your bar X one, and then your cholangioscope and your basically, and then your Erby unit or whatever you use for energy. And so it's like, how many more boxes are we going to fit on a cart or a wall or a boom? And the smaller and the lighter, the better. Actually, I would love it if you guys went to an Apple TV size, because then you can just use command stickers and stick it to whatever you needed to.
And there you go.
So that's actually how I have my Apple TV stuck to the back of my regular TV so that it doesn't flop around. And so far, it's worked. So, okay. So, what are some of the when you set up the scope? Either one of you can answer this one. Like, what the process of pulling it out of the box, getting it ready. How many steps are involved in that, or what are some of the key things that the endoscopist should know when they're getting ready to put the scope down?
I'll give a quick answer, and Jeremy can fill in. We did some early experimenting with this to see how intuitive it was for a tech that knows cholangioscopy to set it up. One of our early cases, we said nothing. We just put the box in front of a tech who had never done a Dragonfly case, and they were training someone who has never done a cholangioscopy as a tech. We said nothing, and they got it done successfully, knowing exactly what port was for what, where to plug in this thing and that. So we basically designed it to be as integrative as possible. It's very intuitive. It may look foreign, but in terms of usability and what the techs have to do to set ours up versus what they're used to, it's actually virtually the same.
Yeah. There are a couple of small nuances when utilizing the product. You want to leave the catheter. You are spinning this catheter inside the working channel of the scope. So, if you've got this scope channel full of contrast because you've, done a cholangiogram and you're with suction and everything else, we're not suggesting that you have to flush the scope channel, but throwing some lube on the catheter is good because you are transmitting torque from the top to the bottom. Mm-hmm. So that's one thing that we always give a suggestion on. And, we do make a custom biopsy cap that integrates the handle really well, because that little biopsy cap actually makes it tight. One thing I did not mention is we even wanted to make a great strap. So we know the frustrations of strapping things onto endoscopes. So we even tried to make a great snap or great strap, and you'll notice that. But yeah, the integration is pretty simple. If skilled tech's not going to have a problem, lube it and go down. Obviously, when you're trying to torque and rotate, elevator needs to be in a down position. And that's just one thing to keep track of. If you're not seeing the rotational movement, there's something that's stopping. It's an elevator or something.
Yeah.
But the thing that I think is really important for people to come away with when a clinician is using this is there are times, very distal duct or in a very tight bile duct, where tip deflection doesn't work very well. And the reason tip deflection doesn't work very well is there is an arc that you need to tip deflect to put it in the right direction. But in a very tight and small anatomy, rotation will work.
Mm-hmm.
So you have that extra degree of freedom, and that's clinicians tell us the stability and maneuverability in the very distal duct or in a tight situation is nice because that rotation is something that they haven't had in the past. So that is, I think, probably one of the most unique advantages of Dragonfly.
To Jason's point at the very beginning, when he talked about we're used to rotating as endoscopists. I mean, I think anyone who's been taught by a very good colonoscopist, they're always told that you shouldn't really be using your little wheel or your big wheel very much. You should just be getting everywhere you need to by turning, clockwise, or turning the scope, torquing the scope. And you can get around a lot of turns just by torquing. So I think the same concept that you mentioned earlier, Jason, about doing that in the bile duct, it makes sense. It makes a lot of sense to us. In fact, I look at the way that you guys have designed it with the rotation, and it's a completely different form factor than what we're used to. Most of us are used to the four wheels and all that. But I had a podcast on ergonomics with Amadip Shergill out of UCSF, the VA, and she's, I call her the queen of ergonomics for endoscopy. And scope has had regular scopes have had the exact same form factor for almost 50 years now. And this is the first time that you have some type of a scope that has a completely different form factor and how it maneuvers, but it accomplishes the same thing. And it's a lot easier on your knuckles and your wrists and your fingers to rotate, as opposed to getting down there and, just turning little knobs. So I think it's a great idea, a great concept. And hopefully, the scope manufacturers adopt a similar process and put it on their regular scopes at some point, or we get to a digital version.
Yeah. So we had conversations and got some guidance from Dr. Suriel, and there is a direct correlation between fatigue and a procedure, just because you're using tiny pinch forces versus more grip forces. Is your body in a neutral position? That's another critical factor. And so, yes, we thought about that, and we hope that this is a move in the right direction related to ergonomics. What's interesting is, and I think it's especially, for the young endoscopists out there that are just getting started, if companies start thinking about ergonomics, the earlier the ergonomics can be paid attention to, you hope that there's a future impact on reduction of endoscopy related injuries.
Yeah, I think a completely different tangent, but we're talking a lot in the societies about the workforce of GI and a lot of people leaving because of retirement. It's not necessarily due to reimbursement, but there's also injuries and neck pain and back pain. So the better you learn to be ergonomically sound in the beginning, especially with products like this, the longer your career could be potentially, and that would save patients as well.
One thing I wanted to just point out, I have a couple quick things to add. I find it really interesting when you have a new device in the hands of a physician, and again, some of the movements may not be super familiar with them in the beginning, and may have a hard time getting rotational control or tip deflecting, etc. But I challenge anyone listening that's a physician to tell me that they know exactly how their current cholangioscopes are going to maneuver when they push and rotate the up, down, left, right dial, right? We all know it's kind of somewhat guesswork when you're in there. It kind of moves in an X pattern and it's very unpredictable. There is no precision of movement. That's one thing we wanted to address with ours. There actually, for the first time, is precision of movement. It's built in. It literally only rotates and then goes up, down from 6 to 12, right? I think I like to bring up an example. Shout out to my old Fuji guys. We back in the day, I did a lot of research on some of the old platforms. we were actually, one of the biggest selling points we had back in the early 2000s was just image. Literally, you would go in there and try to sell on image. But what we found was when the doctors were having a hard time feeling comfortable with the dials, they never got past the fact that there was a great image in front of them because they were too worried about what was in their hand. I think the same thing could be said about something that's novel and different in their hand. There may be some just differences in how you operate something in the beginning, and you may not be able to appreciate downstream all the other things. So I would just, it's my little public service announcement of just be patient with how this operates. Let us and the Medtronic team coach you and how to optimize the use of it. And I promise you, you're going to be able to realize some of the benefits we've talked about here.
So, no, I agree. I think, one of the biggest problems for physicians in general is the mindset of, we've always done it this way. Why would I change and do it any other way? And I think you have to, I tell people, if that's your mentality as an interventional endoscopist, you're on the wrong field. You can't be an interventional endoscopist and live by the dictum of that. I've always done it this way. I'm not going to change. It's such a rapidly evolving field with new indications, new procedures, new techniques coming in all the time that if you're not willing to explore new things, you really aren't in the right field. That's just my personal bias, and sorry if I offend anybody, but I feel that way that's the truth about it. So sorry, go ahead.
This trick was not.
Yeah.
Nobody knew how to use an axial stent until they learned how to use an axial stent, or a suturing device, or any other cool innovation. So, I would the final thing related to like just using it in general. When in doubt, use smaller movements, micro movements. I mean, this thing has the ability to do, barrel rolls. So, if you're doing a movement and you just got to be patient with the result, because if you want to move millimeters, move at millimeters. Just the slow and steady wins the race with this, because it is a precision instrument.
Absolutely. So let's move on to the clinical use cases here, because, we've talked a little bit about stones. We've talked about strictures. So, one of you guys why don't you tackle some of the indications that we would use cholangioscope for as well? I mean, specifically Dragonfly, but obviously, let's talk about cholangioscopy in general.
Yeah. I think if you're entertaining the idea of using Dragonfly, I would encourage you to go ahead and try it on that patient that had a prior cholangioscopy and you didn't get the end result. Mm-hmm. Now, that sounds like we're biting off a lot there, right? But we've seen it on multiple occasions, especially in the stone procedure. There should be one expectation, in my opinion, and one expectation only: that first procedure, complete fragmentation of a stone should be achieved. Not that you can get every single stone out. We know that if you bust up a bunch of paint stones, you might have some fragments in there that are difficult to sweep out, or you capture them with basket, and it's a prudent thing to do to place a stent and then bring them back as a follow-up. Or even in the bile ducts, you might place a stent afterwards for a variety of reasons. Maybe the patient has a stricture or whatever. But complete fragmentation should be accomplished. And if you can't get that, I believe the technology is failing you. And so I would say do it.
Yeah. So we got large stones, obviously, the 4.5 inch, and that's actually I mean, for the audience, I had the opportunity to use it about 2 or 3 weeks ago. And the case was somebody who had failed cholangioscopy on 2 separate occasions and had an index ERCP as well. So this was their 4th ERCP, and we were able to clear about almost a 3 centimeter stone out in probably 30 to 45 minutes. And, that was it. No more ERCPs for her. But, she had, I think, 4 in 7 months. It was somewhat of a ridiculous number. So definitely a case to use it. Jason, what about biopsy of strictures or just mapping out strictures? What's your take on that as somebody who's helped to develop this?
Well, I mean, it's quite simple. I mean, our technology unlocks the ability to take bigger bites with a novel biopsy forceps. I don't know if it gets more straightforward than that. We We also were able to incorporate other design elements to the forceps that our folks at Render were help to develop. And that's just the ability to rotate the forceps. It also kind of cantilevers too, so you can push one jaw on one side and it kind of like forms like. And so it's just a novel. It's our first entree into taking bigger bites. But as I alluded to earlier, we can't really go into details. But there are ways to innovate on top of that too, right? So like the future of Dragonfly is still very young. There are lots of ideas that are in the mix, and that's kind of what propels us to keep innovating.
Yep. I want to add a couple other areas where I think Dragonfly is really beneficial and novel. And it's been alluded to and talked about, but it is the distal bile duct and the distal pancreatic duct, a stone or a stricture that's in those areas, or even in a situation where you're wanting to just look at the very distal bile duct. Your question whether you should do an ampulectomy, and you're going to look at you want to look as far as you can go. By not having to tip deflect in that distal bile duct and rely on rotation, you actually can see things. Even with 1 or 1.5 centimeters of scope in the channel, big advantage. And I know at some point imaging is going to get better with every cholangioscope. IMAC does a good image. We do have best in class image. So when just the visually by a visual impression of a stricture is impactful, but I think we also, because it is the plastic catheter, I think that it can be manipulated in a really complex anatomy. There's the case that was done in Ohio that had a really tortuous duct. It looked like an S shape, and highly experienced clinician, and they were able to get there. And literally, when you look at the fluoroscopy on this, Dragonfly is literally making a complete S. So I think the flexibility of the catheter also has an impact in really complex, difficult anatomy. And I would challenge clinicians to challenge us with some of their most difficult cholangioscopies. I think it's a bold statement, but we think that we can provide patient benefit in those cases.
Yes. Just to build on that real quick, you kind of get the best of both worlds with Dragonfly. If you ever hold Dragonfly next to a conventional cholangioscope, you'll actually notice it's a little bit more supple, so it's not as rigid, and so you get the benefits of a somewhat softer, slightly more flexible catheter, but you also get the internal part with the way we develop the internal guts and the rigidity of our biopsy channel. You actually get the rigidity of the internal guts to hold you in place. So you almost get this, not an FDA claim, but you also almost get this self-centering effect of the device. So it's less prone to be stuck against the wall and more prone to just kind of fall into place correctly when you're in that.
Yeah, no, and that's something I noticed as well. So I've done 2 cases so far, and on both of them, it seemed to be softer in my hand when I was putting it down. And on the first case, she had one of those weird duodenal bulbs where I kept falling out into the first portion of the antrum, and the scope, actually the Dragonfly never actually never moved. It stayed right where it was supposed to be the whole time. I was having to readjust because the ERCP scope kept falling out, but the Dragonfly actually never slipped. And I attributed that to the way that it's a little bit softer and it kind of held its shape longer. So I liked that about it. So that kind of brings up another problem though. So Jeremy, you said, if you have a hard cholangioscopy, consider using a Dragonfly or give you guys a challenge. So in this world where we live in, with hospitals being very cost conscious, and at least in my territory where I practiced, we are tied into another manufacturer with a contract, and so it becomes hard to add another device that is not more expensive necessarily, but it's has implications when you add your device versus the existing contracts that you have. So how do you convince a hospital system, or how do you convince a local CFO that this is something that we should be able to use from time to time, or even replace if that's your goal? But like, how do you get that conversation started? And for any of the endoscopists out there who are listening, who do run GI labs and they want to use this, how do they get not around, but how do they do this without upsetting the apple cart, so to speak?
Yeah. I mean, I'm very familiar with the contracting space. I used to work there.
Here he invented
And no, I didn't invent it. No. By the way, just as a general statement, if contracts are going to block the gaining experience with the new innovation, shame on all of us.
it.
Like innovation, you don't even know if the innovation is going to be impactful until it gets in your hands. So if people are being blocked from even being able to use it, I don't think that that's a good place for the GI endoscopy world to be in. Because actually what that does, it discourages innovation. So we need to be encouraging innovation, not discouraging innovation. And I get contracts exist and there might be very rigid contracts, but I can tell you there are procedures with the existing products that are not going to be as clinically efficient. I'm not going to say that they're not effective, but I think that we have an opportunity to do things that no other cholangioscope has to can do. Does that mean that 100% of your cholangioscopies need to be Dragonfly? I wouldn't even go there. I would say that if you're having repeat cholangioscopies, you can make the argument that there needs to be another solution for at least some of your procedures. So the only way to get there is to I hate to say it, demand it. Like if there's a 90% contract on the total endoscopy spend, having a few cases that are done with Dragonfly probably doesn't really put it in that number. It's actually a relatively small number, but it can be impactful for your patients. So, I could go on a soapbox about this, but I won't say any more than it's time for physicians to say, you know what, we don't even know if this is going to be a clinical benefit until we try it.
Right.
And I've had failed procedures, and I should have the expectation that my technology will get me there in the first one, success in the first one. So that's the argument that I would make to a physician. It's actually the argument that I would make to hospitals is that, especially in tertiary referral centers, places with fellow programs, fellows need exposure to all new innovations in interventional endoscopy. And I think the leadership fellowship program should make those available.
Jason, anything to add, or maybe even talk a little bit about learning curves on the Dragonfly versus for people who are familiar with cholangioscopy?
The only thing I would add, I mean, Jeremy was already touching upon it, but it's honestly the responsibility of the industry, the future, the teachers of the future, interventional endoscopists in the world to bring in every technology. I mean, this literally goes for every technology that's being introduced. Everybody deserves a shot, right? From an entrepreneur, innovator's perspective, if it's novel enough to get someone's attention and there's a cool story behind it, it's worth a shot at any academic medical center. That's a no-brainer. In terms of a learning curve, I mean, we've seen cases where doctors get it right away, 1 or 2 cases. They already seem like pros. There are several that just take longer. So on average, we've heard 3 to 5 is the number. But if it's more, it's more. If it's less, it's less. There's really, what I would say, my plea to the industry or the physicians that are going to look at it is give it the fair evaluation, right? If you're used to something for 10, 15 years, please don't try to make a judgment on it in 1 or 2 cases. That's a little bit unfair of the bar to set in front, especially when the first case or 2 may be just getting familiar with the movement. So, all we ask to honor the effort that has gotten to this point of getting something like this novel to the market is to give it the fair evaluation so that we can, have the right assessment and hopefully be a quieter lab in the future.
I want to add one thing to that. I do get a sense that the younger the endoscopist, the easier it is for them to get the movements, right? They don't have necessarily ingrained 15 years of muscle memory. And when we've had fellows that have used it during really complex procedures, and I was at a large center that is in Minnesota doing some of the early cases, and the fellow turned around and was like, "Oh, you mean it right's right and left's left?" And then I just tip up. I'm like, yeah. He's like, okay, I get it. And he gets it in his hand and he just goes right and he goes left and he goes up and he goes down. And so it's kind of funny. But I think that the cholangioscopist that is highly experienced, it doesn't take much. I think, and those cholangioscopists fully understand the macro movements that are done with the duodenoscope and how those interplay with the micro movements done with the cholangioscope, and it ends up being a good experience.
So, do either of you guys think that this is a procedure that requires proctorship? And I'm not talking about cholangioscopy, because I think if you're doing cholangioscopy, whether it's, SPY or IMAX or Dragonfly, I mean, if you've never done one, you need to be proctored a little bit for that. But if you're someone who has some experience with cholangioscopy, does using a Dragonfly, would that new physician benefit from a proctor? Is that something that needs to be thought about? Or is that something you think with the assistance of your sales force can get passed?
Well, I think we can use Boston Scientific as an example. I mean, they taught a lot of clinicians how to use spyglass through preceptor and proctor type of programs. I think that we would want to replicate that. And I think Medtronic is actually looking into how to replicate some preceptor or / proctor programs. I think it's one of those things like if you're not high volume cholangioscopist at the current moment and you want to add this into your practice, I think that is a good recipe.
Yeah.
I think that if you're a clinician that does a reasonable amount of cholangioscopies, I don't want to put a number on it, but let's call it, one a week or so, then you're going to figure it out on your own.
Yeah. And I think that it also opens a whole nother debate that we don't really have time to go into, but I think there's also within the interventional endoscopy community debates about, really, does everyone need to be doing cholangioscopy? Does every center have to have it or not? I mean, obviously, from a sales perspective, you, Boston, and Microtech would love for everyone to buy one, but the reality is, does the hospital that has 50 beds or 100 beds need it when they can just send it up to a hospital that has 600 beds? And that's a whole nother can of worms that we won't get into today, but something more to think about as well.
Yeah. My opinion on that, quite frankly, is if you're doing a reasonable number of ERCPs, you should have the ability to do cholangioscopy.
Yeah.
Primarily, in my opinion, for stone management. I mean, if you got an indeterminate biliary stricture, you probably need to get to a cancer center, right?
Mm-hmm. Mm-hmm.
But if you got a large stone, I know if I was a patient and there was a doctor that was competent in ERCP and I had a large stone, I'm already there. I'm already under anesthesia. Can you safely make an attempt, without hurting me?
Yeah.
That's it.
The last thing I was going to add is that, quick shout out to Medtronic that has invested a lot of time and energy into this effort. I have never seen an organization work so hard to get their force ready to support this type of effort. One of the biggest values that they bring to the table is they have so many different platforms of technologies that actually suit many areas of the GI lab. So now, including Dragonfly into their portfolio, now increases their presence into the HPB space, and their clinical teams are second to none. The reps and everybody in between are hungry to be a part of your lab, and they are ready to deliver the goods and be there to support you. So, we have a full team effort that is that's approaching the market. It's ready to embrace this change that's happening.
Yeah, and we actually didn't talk about in the beginning, and that's my mistake. Is can you guys talk a little bit about the partnership with Medtronic, how that came about, and what that is? I think, when people look up Dragonfly, they're going to most likely end up on the Medtronic website. So, kind of talk about that relationship, how it came to fruition, and what that entails.
Yeah. Without providing too much detail,
just basic.
The basics are, through the time from concept development through FDA, we were having some communications collaboration with them about what we were doing, and then as we started to get towards FDA, we were like, you know what, this could be a valuable technology in your portfolio, and that's when we announced the distribution agreement. The good thing about that is they've got a full field. They cover all major markets. They've got clinical support teams, education teams, and so they are the commercial. They are the commercial effort for Dragonfly. Now we are side by side with them. We go in the field with them. We conduct procedures with them. But our goal is to really get this fully integrated into their organization. So we've been closely collaborating with them for a bit now.
Okay, great. So we're getting close to the end of time, but just a couple more quick questions. But maybe they're not quick. I don't know. But what about the roadmap for Dragonfly? What can either of you share about what us as proceduralists can expect to see in the coming years? Obviously, we have iteration 1, but what are some of the things, whether it be changes to functionality or whether it be accessories, what are some of the things that we can expect to see as time moves forward?
Well, I think all products that get introduced need to be iterated. There's always improvements. So there might even be technology improvements that are in Dragonfly that increase its potential capability, right? A sensor getting better for imaging, or maybe the sensor gets better and smaller. Does that start to make things even better? I can assure you, our goal is that Dragonfly will have a next iteration. We already know what we want to do related to functionality. We don't want to tell that to the public yet. But Dragonfly is going to get better. We believe in the future. I think the biggest thing that I look at is, what does the world of a larger working channel open up for us related to additional accessories? You can have a bigger biopsy, but if you got a really fibrotic wall and you need to take tissue on a sidewall, and you got a limited space, and it's hard to drive a forceps directly into the wall, are there ways to take biopsies more from a tangential approach?
Mm-hmm.
I think that is a real opportunity to innovate, and we have some ideas around that, especially in a situation where you don't have just like a nodular mass that's sitting there right in front of your face.
Yeah. So I'm going to ask a question. I don't know if you're allowed to answer it or if you guys want to answer it, but I'll just put it out there. So with this relationship with Medtronic, can we see a ERCP Genius or a GI Genius version or AI? Not today, obviously, but maybe in the next 3 to 5 years?
Well, I think that we can speak to this outside of Medtronic. People that are paying attention to the AI cholangioscopy space know that there's multiple entities working on AI and cholangioscopy.
Yeah.
We've had a front row seat to one of those, and I think it could be beneficial, providing you a higher level of suspicion, almost validating what the clinician who is experienced already knows in their heart. And but how do you make everybody the expert related to visualization? You build in an AI for it.
Absolutely. How about you, Jason? Anything you want to add to that?
No, except I think I go back to the mindset. When you have a more of an infinite mindset and the concept of we believe there's a better way, you're always challenging yourself, even if you've just gotten something to market. And what's important is to stay focused on what we have developed right now, which is our minimum viable product. Everybody knows is Dragonfly, but we hope that someday in the future, with the right partners, that there's going to be the next generation versions of this out there that is improving upon the bar that we've already set into the market.
All right, I'm going to give you guys a sentence that I'd like for you guys to finish each. Cholangioscopy will be the standard of care for blank when blank. It's a hard one.
Yeah. This is my stall tactic. Can you repeat
Yes. Cholangioscopy will be the standard of care for blank when blank happens, or when, well,
I think it'll be the standard of care for stone management when it's just easier.
that's perfect. Yeah.
And I think that, even if you could take something out with conventional ERCP approach, let's say it, which is actually gets more aggressive as we speak. Dilation assisted balloon extraction has been out there for a long time. A lot of people do it. People use lithotripsy baskets and other means to get things out. But when I watch stone procedures, let's call it on stones that are 10 plus, I'm like, man, it'd be so easy if you just crack that thing in two, you can just sweep it out, right? But you can't take an hour to crack it in two before you sweep it out. So if you could make it safer and make sure it's more effective, cholangioscopy should be standard of care for medium to large stones.
Yeah. I think that's definitely, I think it has to happen, because kind of getting back to the earlier analogy I made about, we should be able to see it. I also think that when it gets cheaper, and for me as a person on the sidelines watching, I think now that there are 3 manufacturers of a cholangioscope on the market, and maybe more coming, and that's just going to drive everyone to, number one, innovate more, not just iterate, as you said, and Jeremy, but innovate. And I think it's also going to help bring costs down. And once it gets cheaper to the point that, it can be used easily and more more readily, then I think more people will do it. And I think that's when it's going to become the standard of care. I think it's something that needs to be done more, and it's not being done enough of, So, well, with that, I want to thank you guys. Before I say goodbye, I want to tell, my 2 public service announcements. Number one is for any fellows or young physicians listening: join your societies, join the ASGE, join the ASLD, FIGHT, whatever it is, so that you can get involved and help to strive change in GI. And if anyone out there is struggling with any mental health issues, definitely seek help. It's not something that you need to be ashamed of. Everybody has challenges. So once again, Jeremy, Starkweather, and Jason Ylizarde, thank you both for joining me. You spent a lot of time with me, and I really appreciate it.
It was a fun conversation, and thank you for inviting us.
Yeah, thank you so much. Pleasure to be here.
Please hit that like button and that subscribe button.